So just as a little introduction, I'm a facial plastic surgeon. I've been at Westlake for almost 5 years, coming from 20 years of practice in New York City. And it's been, love Austin, love being here, and do a fair number of fillers throughout the face. I focus only on the face, though. I don't do anything else. Chuma, what about you?
So thanks for joining us. I see Dr. Bosley from Dallas has joined us, and some other people who I recognize. So thanks for coming in. And Dr. C, thanks for setting this up. This is actually my first Instagram live, so I'm pretty pumped to share my experience, and also to obviously, kind of learn from each other as we're doing this, and also learn from the audience. So I'm Dr. Chike-Obi. I've been in Austin, in Mode Stefan. Hi, how you doing? I've been in Austin about 7 years and practiced 7 years. So my practice is focused on body contouring and breast contouring, breast and body, with pretty large and growing facial injectable base. And that's what we decided to talk about today. It's been a great run so far in Austin, like I said, 7 years. And yeah, it's been a crazy couple of months for most of us. So, we're basically trying to get the information out there as we, at least in Texas, are starting to get back into some sense of normalcy, getting people, feeling good, looking good. And so, yeah, Dr. C, if you wanted to continue, let's go for it.
So, right. So I just, I think in my practice, fillers have really two roles. For me, fillers are to be useful in patients who are sort of too early for surgery. And the second role is to augment surgical outcomes. And probably the third role is patients who probably could use surgery, but just aren't in that mindset or don't have recovery time or that sort of thing to talk about. And so I think what I think would be interesting would be to start sort of talking about regions and how we treat them with fillers, and why, how we treat them, why we decide to treat with fillers. And so, Chuma, why don't you start? Let's start with talking about the eyes, because the eyes are kind of one of the areas that most patients ask a lot of questions about. They hate their bags. They hate the way they look tired all the time. What kind of patient is the right patient for filler around the eyes?
Yeah, so I feel like the eyes are probably the most important part of the face. People say the eyes are the window to the soul, which is kind of cliche, but there's a lot of truth in that. Taking a step back with how I view facial fillers in my facial practice, I see fillers as filling one particular role with facial rejuvenation, and that role, for the most part, is really adding volume. Okay, now it's possible for fillers to, once you get sophisticated enough as an injector, you can use fillers to help with potential, fine lines. You can help with imparting a bit of a lift effect, but primarily for me, fillers help with my patients who I see who have started to lose that 1% of collagen per year. That's about how much we lose per year, starting roughly at age 21. So that's how I see it. And then surgery usually fits in when we start to see a lot of excess skin, excess tissue, so-called descent of tissues, when things start to kind of fall down. That's primarily where surgery fits in. So I view them as kind of being a little bit synergistic for the most part. And the third piece with the face, arguably the body in general, the skin in general, is the quality of the skin itself, the texture, things that are not really addressed by surgery or by dermal fillers. That's a huge topic. That's probably the subject of another talk. But going back to the eyes.
Yeah, talk about the eyes.
Yeah, that you talked about. The most common kind of area that patients bring up to me that bothers them, that starts to show their age, is this region, called the tear trough area, the under eye area, where over time you start to see kind of a hollowing effect in some patients, loss of volume, perhaps kind of dark circles. So that's the main area that I feel like patients tend to bring up. And the anatomic reasons are just like I described. It's really a loss of volume, and that bone, the infraorbital rim, starts to show more than it should. And the correct choice with dealing with that area is to consider one of a number of dermal fillers to augment, to add volume, and give a look that is more youthful for patients.
So let's get a little bit specific then.
Sure.
So if you're looking at so for me, in 99% of patients, I'm going to go with Westlake.
Okay.
Not being promoted by any company today, so I think we can talk. And
Sure.
And I think we can also talk off-label since we're not, being scrutinized that way. So
Yeah, I love it.
So for me, Restylane L is the way to go around the eyes. And I kind of switch back and forth between using a needle versus using a cannula.
Mm-hmm.
And so I started using a cannula about a year ago around the eyes. And then I had a lot of patients sort of get dizzy and lightheaded, and they couldn't tolerate the cannula. So I was like, all right, well, I'm going to go back to the needle because I know what that's about. But
Sure.
then there's bruising with the needle and cannula almost none. So now I've switched back again to cannula. So what is, and I think the cannula gives the advantage of your being able to feel the different ligaments and compartments around the eye,
Yeah.
and know if you're breaking through or not. Sometimes you want to break through those, and sometimes you don't.
Yeah.
So what do you think, Chuma? What's your sort of favorite technique
Yeah.
for the eyes?
I think that's fantastic. So just to be clear, so everyone can see, there's some questions coming through here. We'll get to those a little later. So the tear trough area is this area right here. If you were crying, you'd imagine tears running down through that area. So I have used both. In terms of tools for the work, I've used needles, I've used cannulas. I tend to reach for a cannula these days because of the issue of bruising. This area has a lot of small blood vessels, capillaries. So I think it's very difficult if you inject enough patients to 100% miss those with a needle. So the bruising is really not a great option, a great outcome. It's unavoidable in some cases, but it increases downtime, and people don't tend to not like that. So I like to reach for a cannula, which has a blunt tip, so that when you are introducing the cannula in, you're not going through vessels and piercing them, causing bruising. Ideally. And I do like the fact that I can kind of tell better where I am with the cannula than the needle. It does require a little bit more push through, more pressure pushing through, that can be a little jarring for patients. So I warn them beforehand before I inject. But I feel like the bruising risk is down to nearly zero when using a cannula, about a 27 gauge cannula for me, versus a needle.
Yeah, and I totally agree. And now, just now, let's get just a little technical, just because it's fun to do that. But so with a cannula, I'm a right-handed surgeon, so I'm standing to the patient's right for the most part.
Sure.
So I'll enter sort of around this area.
Yes.
And then sort of come in medially towards the nose. Mm-hmm. And in through this, and then laterally I'll do it. Typically I need to do a new little pass with a little sharper needle to get in the right direction, and I like to come early. But on the other side, because I'm right-handed, I enter here and I'll be able to do this. Mm-hmm. Come to here, if I'm standing, I just don't have the angle. So I make a second entrance point to come laterally on the left side. and it means just one stick on one side on each patient and a second stick on the other side. And then I found that patients really don't have much pain with this, but it's a funny sensation, which is
It
the reason
is.
I
It
think
is.
some patients get a little dizzy. We have to be careful about, making sure if they need to lie down, they can lie down.
That's for sure. Yeah. So I think that communication before injection is key, just so people know what to expect. Needle phobia is a very common. The last paper I read on this, about 1 in 5 patients have some degree of needle phobia. So I think having that conversation beforehand as to what to expect during a session, it doesn't take very long to inject. Even when you do it kind of artistically and draw it out, about 15 minutes max. But having folks understand what to expect. The needle points, it is true, speaking of technicals, so the way I approach that area, I typically will make, the cannula is blunt, so you typically have to make an entry point with the needle, at least I do.
Yeah,
I make that entry point kind of a pinprick with a needle that's very slightly larger bore than the cannula. So I make one close to the mid-pupillary line, a little lateral to it, just like Dr. C does. And then I make one out here at the lateral orbital rim. And the length of my cannula is about 1.5 inches. So that through this entry point, I can go in towards the lateral canthus, the medial canthus rather. And I'm typically trying to get that cannula definitely under the muscle, more often under the, it is under the muscle, so above the periosteum layer, the supraperiosteal plane. So I lay that in using what's called a linear threading technique. Basically, introduce the needle slowly, and it's basically painless at this point, and then inject slowly as I'm withdrawing out. I do a couple of passes, as many as needed. And then once I've filled that medial area appropriately, I come out lateral and then make my entry point and basically do the same thing. And then I go around the table to the other side. I typically start with the patient's left side, just out of habit, and then I go around. I typically will look before I start injecting for asymmetries. Most of us, when you look at anyone on the thread right now watching, you can look at your face in the mirror or take a picture. More than likely, one side of the face is bigger than the other. So some of those things are important when you're injecting patients so that you can not exacerbate that natural asymmetry, maybe help improve it, or at least be aware of it so that as you're injecting, you're doing the right thing.
Yeah, that's an excellent point. The question about asymmetries come up a lot, and
Yes.
and I have I sort of I try in both in my surgery and my filler philosophy not to really try to correct natural asymmetries. I don't think we can. If it's a bony asymmetry, I don't know that we can really correct that. And once we start trying too hard to correct asymmetries, we might be chasing our own tail a bit, and we'll never really get exact symmetry. So yes, I think we can make improvements to make people look better overall. And asymmetries due to fat loss or tissue laxity are correctable. But those underlying asymmetries of bone, if it's there, which everyone has, I think I tend not to like to chase. Chuma, what about, are you using Restylane?
So I use, so just to, I know there are a few, certainly practitioners, injectors who are watching this. I'm assuming some are not injectors. So I'll back up a bit and explain what Restylane actually is. So there are a few different types of fillers that exist. Most of us injecting today, I would bet most people are using some filler that has hyaluronic acid as the active ingredient. HA is a complex sugar that exists outside our cells in our bodies. Everyone has it. It's a natural, essentially natural substance that you can't really reject, and it's very agreeable, very pliable, very soft, and workable. It gets more complex than that, but essentially Restylane is a hyaluronic acid filler, which I do use as well. There are others that exist from different companies, and I use those as well, as long as they have the right properties for the tear trough area. Okay, this area has the thinnest skin in the body, the lower eyelid does. So you don't want a real thick product there, even if you're injecting deep, because the risk of problems is just higher, sometimes to unacceptable levels if you use too thick a product. So Restylane is a fine product. I use it as well, but I use others in that area.
We're going to get to lips later.
Oh yeah, nice.
So we're going to get to lips in just a little bit. I just want to bring up the fact that this area around the eye is a really pretty complicated anatomic area.
It is.
And so for areas of the tear trough, which are fairly close to the eye, I think Restylane is a great idea. But many patients also start to lose fat and have deficiency in the upper cheek that kind of blends in with that eye area.
Mm-hmm.
So, and so when I think about this problem area of sort of eye looking tired, but also upper cheek volume contributing to that saggy look, I like the idea of filling to treat both the cheek area and the eye, the tear trough area. And I'll do that either at one sitting or in two separate sittings. But I tend to do things a little bit in reverse to what most injectors, which is I like to fill the tear trough first, see the result I get, and then I can augment the cheek if necessary, versus filling the cheek first. And that's just gives me, I think, a better sort of more natural look. Having said that, the filler that I use for cheek in that area is not Restylane typically.
What do you like to use?
So it depends. It'll either be a thicker, more cross-linked Restylane product like Restylane Define, or I'll go to a Juvederm product, Voluma. And there's been a little bit of controversy about whether we ought to be mixing products from different companies, but I haven't really seen a problem with that, as long as we're careful about how we're putting those things in. But for that deeper cheek filling, I tend to not use a cannula. I tend to use a needle, but I think cannula is fine. I just, for me, a needle. But I like the cannula for the eyelid. What about you, Chuma? How do you think about that whole region?
Yeah, so I love your transition to the cheek. By the way, very smooth. So when I look at patients, so the tear trough, if you look closely at some patients, so basically there's this structure called the cheek lid junction, and that is where the eyelid ends and the cheek begins. And when you look at a youthful face, if you opened up or looked at the cover of like a Cosmo or Laura or what have you, that person on the cover typically has an imperceptible transition from the lid to the cheek. It's typically a smooth transition, and that is what that is the base of what we strive for when we see a patient who complains about that area that bothers them. So oftentimes you see the tear trough area that we described earlier, but in some patients what you see is the tear trough and the rim, and then you see this line that cuts across the cheek like this. That is not a youthful structure, but a very common structure. And so I do agree with you that oftentimes we need to address both areas. I typically would do it together if the patient agrees, to get that look that she or he is looking for. I do typically reach for a hyaluronic acid filler that has so-called higher G prime, which means it's more cohesive and thicker, because those products do a better job of, in my mind, is almost like you're trying to do the work of bone, in the sense that you're trying to provide structure to the area. So when I'm injecting on top of the cheekbone, generally, I'm trying to basically extend the function of the bone to give more support and more structure. And so for me, I do the opposite of the way you do it, where I typically will try to get that base set, and then I can go ahead and address the area above it, which is the tear trough lower eyelid area. Someone asked earlier about, I saw a couple of questions. I don't want to digress, but they seem relevant. Someone asked about Restylane Define, I saw, for tear trough, which I think is, I don't typically jump to that filler for tear trough, but I see no reason why not, if that's your preference. And then I saw a question about fat grafting. Did you want to get into that yet or not, Minas?
We can talk about fat grafting. But let's talk about it in the sense of comparing what we just said, right? So, and let's finish the cheek idea, because the cheek in the inner that supports the eyelid. One thing that we can do that is, we see patients that are older that have lost strength in the eyelid who are starting to get saggy. And so in surgery, we as surgeons are used to being able to tighten the lid if necessary to make sure that it doesn't get saggier during the healing process. But that saggy eyelid can also be improved, I think, with the correct placement of filler, because with filler, we can create support into the eyelid. Similar, by pulling your cheek up, you get the eyelid more supported. Well, filler can also support the eyelid as long as it's done correctly. And so those are, kind of, but in terms of fat grafting, Chuma, so what I don't, my own personal bias is that I actually like fillers like Voluma better for mid-face augmentation than fat grafting. I like my fat grafting is commonly performed either alone or in the context of facelifting today. And a lot of surgeons are using fat around the eye area to try to help to give volume that's more permanent. But at least in my hands, I get maybe only about a 50 or 60% permanence with the fat. A lot of it goes away. And with fillers, I know what I'm getting. So actually, I prefer to use surgical techniques that move the malar fat up and use fillers if necessary in addition.
Yeah, I mean, and you are primarily a facial surgeon, and so I love the detail for sure. I tend to agree with some of that, actually. I think that, listen, fat is fantastic, and I do a ton of fat grafting, fat transfers, usually to other parts of the body. But I think when you compare fat grafting and filler, to me, I think the fat grafting, there are two things with that. I think fat for structure is not a great choice. Some of these man-made fillers, if you were to squirt some fat on a table and look at it, it would not have any structure compared to some of the fillers we've described, which would have the structure. So if you're looking at someone's cheek and trying to impart that, kind of structure, I think fat would not do well. I think if you're trying to volumize areas, add volume, I think fat's a good choice, and it works great for some people. I tend to notice some of the same issues with the face that you do, which is definitely more unpredictability compared to filler. Some of the fat cells will be lost, and that percentage is variable depending on a lot of factors, including the surgeon, the patient, etc. And so I typically feel like, and then on top of that, the fat is, it's metabolically active. Okay, so, and it tends to have more bruising in my experience, and it takes longer to kind of settle out. So with all those things, I think fat grafting by itself is a bit tougher sell for patients who want to kind of come in on Friday and go back to work on Monday without having this
it doesn't work.
This prolonged thing. I think if you're doing someone's face or whatever procedure, a brow, eyelid, fat as an adjunct makes sense.
Something that requires recovery anyway. So fat.
I think as a standalone, I tend to not offer that too much.
But what about longevity of fat? I mean, are you seeing 100% take?
No, no, that's far from it. So and this is like my talk with patients with fat grafting, um, in a couple of areas of the body, including the face. I think that fat is using techniques available today in the U.S. You know, most of us can't use stem cells and things like this in this country. I think there's going to be a loss. I tell patients to expect about a 30% loss of what's done at 6 weeks on average. And so, given that, many times we tend to kind of overshoot, overcorrect, hoping to make up for that loss. But it's definitely an attrition rate of the fat. Like some of the fat in my hands, anyway. I don't get as reliable a result with fat grafting as I do with fillers. Now, if there's a patient who comes in and they've had fillers like for a couple of years, and they would like to try fat, that's in my mind is a more appropriate person to go to fat grafting with, because they understand kind of more kind of first choice and they want to do something different.
Right.
Yeah.
Right. So we had a really good question here about creating a structured high cheekbone. Can fillers do that? To give the question asks about an athletic look.
Yeah.
And I think it's a really good question because it drives the point between the different types of fillers. For me, if I'm going to create a really sculpted high cheekbone, I'll use one of those high G prime fillers like you talked about, like Chuma, like Juviter and Voluma, right? To try to really create structure.
Mm-hmm.
And I think you can do that really well with fillers. Structure the cheeks, structure the jawline, structure the chin, anything.
Agreed.
But if I'm trying to volumize overall, just someone who's lost a lot of volume, then I might think about other types of fillers, like more like fillers that allow for collagen formation around them. For example, Sculptra is one that I tend to like very much for that.
Choice. Mm-hmm.
Try to give better volume overall, temples, cheeks, primarily in those areas. But how do you think about that issue?
Yeah, I mean, I love that you brought that up. I think yes, it is possible to create a structured look as much as the patient wants. All this comes down to basically, in my opinion, listening to what he or she or he is saying in front of me, what look they want. If they have photos to help guide what we're trying to recreate or create, that's fantastic. I think that it is possible to use some of these denser fillers to give that look. The fillers you've mentioned, yes, I've had success with a different filler. Basically, it's called Radius, but it's calcium hydroxyapatite, which is a component of bone. So the filler looks kind of whitish, like toothpaste, but it does a great job of kind of filling deep and giving structure. So I think yes.
Right.
So that answers that. As far as this filler you mentioned, Sculptra, I love Sculptra in my practice. It's a big part of kind of how I view the face. To me, the face, as time goes on and as we age, to me, it's not an isolated, oh, this area is deeper, this is deeper. To me, it's really a panfacial problem. So there are areas where that would benefit from having your own stuff get regenerated, which is your own collagen. And there are fillers that help you do that. The one I like to use currently for that issue is Sculptra, which is polylactic acid is the kind of generic name for that. And it's a different kind of filler because it's not an immediate effect. It takes time to kind of create that collagen stimulation. And patients require a series of injections. Typically, for me, 3 injection sessions about a month apart. And with that, I'm able to look at the patient and say, okay, how can I rejuvenate this person's face? Generally, as we age, tell me if you agree with this, the face tends to kind of almost melt downward. So the volume gets to the bottom and it looks almost like an egg. right side up. So heavy at the bottom and smaller on top. In most patients, we want to reverse that best possible. Have it be like an upside down egg or almost like a heart shape if it's a feminine female, or someone who wants more feminine features, I would say. And so I use Sculptra for me as a foundation filler. I tell patients, listen, we can build up a base of your own stuff with Sculptra in all these areas we've talked about, and then I can use some of the other fillers on top afterwards, layered on top, to get that full effect. Which speaks to a point that I think is important. I think that when patients come in to see me or you, I like to get them on a plan, because this stuff, I think an immediate injection, okay, go home, come back in a few months, I think is not optimal. I think a long-term plan where you kind of know what you want to address when, I think has a better chance of lasting years and giving the look that people are looking for.
So we had a really good question about, let's go back to the eyelids for a second. How do we know if we need surgery for the eyelids or if fillers are sufficient? And so
that's your wheelhouse.
And so I generally think of eyelid problem. If you're getting dark circles and looking tired when you're in your 30s, then typically it's going to be a filler problem. Now, I have patients who have had congenital bags their whole life. In their 20s, they have big fat bags. And I've done blepharoplasty on these patients to get that, because it's a congenital problem. It's not something that's age-related. It's something that's their whole life. And so age is not really the factor, but if someone is in their 30s without congenital bags, they're just starting to look tired and all the time, then typically fillers can help with that. As you get older in your 40s, that's going to be a conversation about what you want for the long term. You want to have fillers every year to try to improve things, or are you ready to think about surgery for a more permanent improvement? And surgery doesn't, when I say permanent, it's really a 10 to 20 year type window. It's not really permanent because we'll continue to age after surgery and then might need something additionally done. But so for each patient, it'll depend on what is their tolerance for healing, where are they in that cycle of aging and looking not as good as they want to look, and what are the impacts of one versus the other. Now, some patients aren't good candidates for filler after a while, because if they have natural cheekbones that are somewhat flatter and the bags are quite large, we'll never be able to camouflage that without making them look like chipmunks. So it's not going to be a natural good result for them. So for me, it's really depending on where patients are and what's driving them, and if they can tolerate the surgical recovery or not. After blepharoplasty, surgical recovery is pretty quick. I mean, within 10 days or so, patients are out and about and looking pretty good. It's not that they're not all healed yet, but it's a pretty short recovery. We had another question about Sculptra and whether it could give lift, or do we prefer thread lifts or anything like that for lift?
Yeah.
And I'm just going to mention this because it's one of my little pet peeves, Chuma, and you might disagree with me on this. And feel free, please feel free. But I don't think, even if we're using a really structured filler like Voluma, I don't think we're really getting a lot of lift. In other words, when we're putting filler out here, if we're expecting to pull the nasolabial fold flat, that's just unrealistic. And you end up, if you put too much filler too close to try to get lift there, then you end up looking like a chipmunk. So I think you can get a really pretty balance of the face with those structured fillers, but you can't get lift. I don't think that Sculptra gives lift either, because it's more diffuse and it relies on your own collagen to work. In terms of thread lifts, I think there are two types of threads, right? There are threads that are placed for volume, and there are threads that are placed to lift. And I don't do any of the volume threads. I have done the lifting threads, and they just aren't that great at lifting. So today, I'm either going to create volume with structure or diffuse volume with filler, or I'm going to do surgery to really lift for the jowls and that sort of thing. I'm not going to expect that fillers are going to give enough lift to improve a jowl, for example. What do you think about all that?
Yeah, that's awesome. So the first issue is the issue of um, when I inject, when I treat someone's cheek, does that give a bit of a lift effect? I would say yes. In my opinion, there is a lift effect, which is different than saying there's a lift.
I
Okay.
agree with you. I totally agree with
So,
that. That the way you're saying that.
yes. So it's nuanced, but I think that if you have someone who has a prominent nasolabial fold on both sides, and that is something they see, which is a common area, kind of first area of interest for a lot of our patients who are seeking rejuvenation. Then I've seen this in my patients. When you kind of restructure the cheek, that has an effect of offloading the weight on here because of the added structure. So you get some improvement here. I don't think it's a huge effect. I think it's actually a pretty small effect, but it's a real effect and a beneficial one. So I do like that, and I exploit that when I'm trying to address, kind of mid-lower face aesthetics. And then once the patient is comfortable, like in young patients, I think that's a great kind of first move who don't have a really deep fold, because then if someone is 27, 28, that might be enough to get that look that she's looking for, and then you're
Right.
done.
Right. And that's a really important point, because we're using fillers to sculpt and create improved heart shape, improved angles, more light and shadowed angles. Even in patients that don't naturally have that, we can give them some of that. So even in
Mm-hmm.
the 20s, we're seeing patients who want a little bit more of that structure, that look like that they get when they highlight their cheeks with makeup. We can do that with filler. And I think it's really very effective.
Yeah,
Now, yeah,
I
I'm
had
sorry.
a point to make about, you mentioned someone asked about threads.
Yeah.
Um, I don't do a lot of threads currently. I got a bit more curious about threads when I was in South Korea in Seoul in November, pre-COVID, but um, and I observed some surgery, and the use of threads is far there's a lot more surgeons per capita using threads in that population than certainly than I see in Austin, or I would say in the U.S. in general. And I think the reason for that is I think one reason, I think it's cultural one, but I also think that they are treating patients who are generally younger with less descent of tissues, so that the threads, even though they do a relatively mild job of correcting, for those patients who don't have a lot, it's great and it's fine.
Yeah.
For a lot of our patients, there's a lot more laxity where the threads, in my opinion, would fall short of the mark
Yeah.
in too many patients.
Now, let's I don't the time is quickly passing, and
It is, man, this is fun.
so let's just talk about jawline for a second,
Yeah.
because I said you can't get a lift, you can't lift the jowls out with filler, but
Mm-hmm.
camouflage, right? I mean, we're getting a lot of patients who have early jowling, maybe like me.
No, I don't see anything there. You look good then.
And by camouflaging along the jawline, we can create improvement of the jawline, but also we're getting younger patients who want a more angular angle of the jaw,
Mm-hmm.
and we can achieve that with some structured filler, right? So,
Yep.
so how do you think about that, and which fillers do you like?
Yeah, so jawline is a very important area for a lot of patients. When you turn, oblique view, most people that I see are looking for a clean structure through here where you can kind of see the bone without anything breaking that up. And what breaks that up is what we call unattractive. The name is a bad name. We call it a jowl, and that's that fullness in this area here that we tend to see as time goes on. And so, can you address that with surgery? Of course. As part of a face neck lift, that would be addressed. Sometimes you can address it with liposuction. When we're treating the neck area with liposuction, we can treat that as well. But it's also possible to treat it with filler in a kind of a roundabout way, like you were hinting at. And that is basically where we inject around that full area to camouflage and make it be less appearance.
Right.
All these contours we're talking about are basically some combination of peaks and troughs, or hills and mountains and valleys. Maybe hills, not mountains, hills and valleys. And so, if you have an area that's full and the area next to it is less depressed, then the full area is less apparent, less jarring. And so we exploit that with this area we're talking about. And sometimes I'll inject the area we call the pre-jowl sulcus, which tends to be a deeper area, and kind of fill that and blend that in a way that doesn't look like overly full. So for jawline, I've used a few different fillers. I think the hyaluronic acid fillers are fine. The dense ones are good. I feel like I get more mileage out of Radiesse for jawline. And Radiesse is that filler I mentioned that's calcium hydroxyapatite. And so you get 1.5 cc's per syringe with that, which is worth talking about actually, kind of what a cc is, I think. I think a cc, a syringe, like it's kind of scary for a newcomer. Wait, what, I need 3 cc's in my face? It sounds crazy. In reality, 1 teaspoon is 5 cc's, which is a very small volume. So it's worth keeping that in mind if you are someone who's considering coming to see us or others for potential filler. So I like Radiesse, to summarize, but there are other choices that I think work well.
Yeah, and for me, I don't love Radiesse for that area. I like Voluma. I think it gives a little bit better structure. For me, a little bit better structure.
Sure.
Radiesse, and the thing I like about the hyaluronic acid fillers in general is their reversibility. In other words, if it is not quite right, or goes somewhere we don't like it or whatever, we can get rid of it and right away. I mean, we dissolve it right away. So it's I think it's really very, very, I like that versatility.
I love that as well. I do.
Before it gets too late, we have to talk about lips.
Yes.
So what are your, do you want to, so I'll start.
Yes,
so
sure.
With lips, I think there are 3 different types of lips. There are lips, and I'm not talking, there are lips, as we get older, we have the upper lip comes down and in, thins down, and we lose volume in it, and we also lose projection of the upper lip line.
Correct.
Lower lip also involutes a little bit, but less than the upper lip, but both of them can get a little wrinkly looking lack of volume. Now, in the patient that has those wrinkly lips that just need a little smoothening, and patients who don't want to, we say lips and fillers, and people like automatically think like overly done, awful clown lips. Duck
lips.
A lot of examples on Instagram with that, right? So for subtle filling, love one of the very thin fillers like Restylane Silk, or one of the Juvederm products, Volbella, that will be very thin. So I love that for subtle filling. For structure, where I want to define the lip line but don't want a lot of puffiness, I like Restylane, right? Restylane. And then if I want puffiness, I want fuller lips, I like Juvederm Ultra Plus. What about you?
Right. So I think lips are one of my favorite areas to treat. I think that I would say, it's wonderfully kind of complex in the sense that there are different morphologies, different types of lips. On top of that, there are different, there's so many variations in what people are looking for.
Right.
Okay. So you have the patient who comes in who says, there's only so much that lip plumper will do, right? So at some point, someone says, what, my lips look like over time, they're thinner, they're less vibrant. What can I do? I think so that's one kind of patient where we're just doing kind of a more subtle job to address them. And a filler like you mentioned, like, I think you said, did you say Silk?
I did say Silk and Volbella.
Yeah. Yeah. Okay. So those are hyaluronic acid fillers, very light, very silky. No pun intended. And those work great for a more, in my opinion, a more subtle lip rejuvenation. When you want more, you need something that's denser. And so Juvederm Ultra works well for me. So most first timers who come in, typically a wide age range, but a lot of times even younger patients in their 20s will come in because they want that fullness. So first timer generally, Juvederm Ultra I like a lot. I use the needle for most of this. I've done cannulas in the past, but I use the needle for most of my lips.
Me too.
Right. So when someone who's had injections for a while, one of the things that I see or hear I'll say a good amount is that patients come in and they say, Doc, I've been having filler, I've been getting my lips filled for a few years, and it lasts, 6 months and it's gone. I ask them what they've had, and if it's something that's like a Juvederm Ultra, then I upscale them to a little bit denser filler, like Juvederm Ultra Plus, which is more cohesive, and in my experience, lasts longer. Also gives a bit more structure. So in someone who wants a lip that has more structure, not quite duck lips, but more than that little bit, then Ultra works very well in my hands. Yeah. Another point I think is good to talk about with lips. There are a few people who are prominent, whose names come up a good amount. Kylie Jenner is one, the most prominent one about what people are looking for or not looking for.
Right.
And so I also look at the ratio of the upper lip to lower lip. You're correct. The lips get thinner and they kind of pull in. They project less with time. And part of that is the lip tissue, but part of that is the bone underneath that starts to resorb. The alveolus resorbs over time. And right. So you project less. And so I ask patients if they want, some people want an upper lip that's a little larger than the lower lip. Others want the opposite. So I always make sure to ask the patient what they're looking for compared to what they present with, because everyone has a different desire, right, as to what aesthetics they want.
Yeah, and so there was a very good question about using the patient previously had Restylane Define in her lips. Mm-hmm. And then now is asking, can she now use Juvederm Ultra Plus? And I think the answer is yes, as long as it's placed correctly. And I don't think there's a problem mixing fillers necessarily.
Right, and that's the key point. I think we all see patients who may have had their treatment somewhere else, and if they come in for additional treatment, if they have any issues with previous treatment, we always talk about kind of erasing the board,
right,
and starting from scratch.
Right.
Okay, and to do that, we typically dissolve, and that speaks to your earlier point about one of the key selling points with hyaluronic acid fillers is that there is a safety valve. If there is a problem, or if someone doesn't like the treatment for whatever reason, it makes us gives us a true artist tool in the sense that we can actually reverse that and dissolve the product if need be.
Right. And then a very good question about, are we planning on doing anything special with fillers around the mouth now with COVID? And so, Chuma, you and I have had a lot of discussion in the last week about what we're going to be doing for our offices to protect our patients and our staff from this COVID epidemic. And although the numbers are starting to flatten in Austin, there's still plenty of COVID around. So what are we doing? And so for me, what I will be doing is, for any high-risk procedure, and for me that means working around the mouth and nose is a high-risk procedure. For high-risk procedures, I'm going to be the only one in the room with the patient. I'm not going to have a staff member with me, so to minimize their exposure. And once the patients are numb, I'll be using an N95 to make sure that I'm protected. Of course, the patients have to pass screening tests and that sort of thing.
Exactly.
But screening questions, rather. But I am personally not planning on testing for COVID before injecting lips. What about you, Chuma? What are your thoughts on that?
You're right, Manaz. We've spent a lot of time, you and I and others in the practice, talking about how, the big question is this: how do we see our patients and do what we are trained to do, what patients want us to do in as safe an environment as possible. So we've decided as a state, certainly, that we need to get on with some sense of normalcy best possible. So seeing patients, we have protocols in place depending on what the patient is having done. All our patients in the practice, skincare, surgery, and everything between, everyone will be screened. Everyone in the practice will be wearing a mask. Patients will be wearing a mask. As far as fillers are concerned, everyone wears a mask until the time of treatment. Okay, so we'll ask you to remove your mask when you're being treated. Other than that, you'll be wearing a mask. And the staff will have, certainly the nursing staff and the treating injector will have what's called an N95 mask, which filters, it's a very high fidelity kind of mask. It filters, certainly COVID and other things of that size, virus particle-wise.
Well, so it doesn't filter virus, but just to be exact,
sure.
It does filter very fine mist. So anything, as we speak, if you're infected and don't know it, you're spewing COVID everywhere. Sure. And so anytime, so the N95s are good. Before we're almost out of time. We only have about 5 minutes left. Real question, will telehealth be available after May 11th for our practices? Yes, it will be. Every practitioner will have their own sort of level of telehealth, but yes, it is available after ongoing at Westlake, Dermatology. I want to talk about nose.
Yes.
Because this is one of my favorite areas to inject. Liquid rhinoplasty.
Liquid rhinoplasty. I love it.
And go to our website, check out liquid rhinoplasty. But fillers in the nose to hide bumps and to create better tip projection and less droopiness can be safely done. And I think you are also treating noses, right?
I am, absolutely.
And for me, I started with Restylane for the nose, and now I've completely changed to Voluma. I was finding the Restylane is a little bit too fluid, and so wouldn't quite always stay where I wanted it. And so now I've switched to Voluma, and I'm much happier with that result. But for the nose, only hyaluronic acid fillers in my book, because God forbid you get some problem with vascular flow to the nose, or it just doesn't look right and you need to get rid of it. The nose is not forgiving. So hyaluronic acid fillers, so we're safe and reversible.
Have you considered, that's great. I think that's awesome when you get great noses, obviously. Have you considered Restylane Lift? Have you tried that?
So no, I haven't tried it. I think it probably worked just great in the nose. But so far I've been happy with Voluma. So until I'm not happy with that, but we may try Lift. It depends if someone maybe has a lot of points on their Restylane program and they want to get more. Use Lift instead of that. I mean, it's possible. I'd probably be more likely, though, rather than Lift, to use Define, just because of the cross-linking.
Sure. Yeah. Dr. Bosley's asking about cannula versus needle for nose. I like to use the needle for my noses.
Yeah, I don't think you can use I'd like to know if Dr. Bosley has used cannula for noses. I just don't think it would be very precise enough and be hard to sort of get in, but I haven't tried it. Maybe.
Yeah, I love nose. Go ahead.
The upper part of the nose, probably it's more mobile. You might be able to get it in, but if we're injecting closer to the tip, unlikely. I also like injecting here at the base to pull the tip up. It works pretty well.
Yeah. I love injecting noses. I like to use a needle, like I said. I use Restylane Lift more than anything, but I think when you look at Restylane Lift and Voluma, you know, they have different kind of languages. That's how they describe it, and there's some differences technically, but they function in the same kind of atmosphere in terms of how much you get it in terms of structure. And so I put my flavor that I like currently. It may change based on what I learn and how things go with just being a surgeon. That's how we all learn. We get better. But I like Restylane Lift. I use a needle. I tell patients when I ask what the issue is. Sometimes it is, like you said, some fullness here, so-called hump. Sometimes it's a tip issue where the tip is not as rotated as under-rotated. So sometimes they have some asymmetric, kind of an asymmetric dorsum, maybe like a little bit of a curve. Whatever it is, we can sculpt with a hyaluronic acid filler,
Right.
And I think they work well.
Right. The only part of the nose that really, in my opinion, should never be injected is this lateral alar area, because that's where those vessels come in.
Mm-hmm.
That's where we get disasters, the blood flow complications in that area. And the other patient that I'm really careful about injecting and is patients who have already had rhinoplasty. There's more scarring in that nose, and so the risk of a complication is high. We just have to, it's not that we can't do it, we just have to be a lot more careful about what we're doing.
Okay, there's a question that's interesting. This, we may have to talk about it separately even. It's a huge topic in my opinion, about dark under eye circles. Because to me, that's actually a multifactorial problem, the darkness. Do you have any comments about that?
I think I agree with you. It's a really bad problem. We have a minute left.
We're out of time, man. This is great.
Cover it. But telehealth or message one of us, direct message one of us, and I'm sure we'd be very, very happy to answer. Right?
I love it.
All right. Well, thank you everyone for attending.
It's been a blast. Yes.
Awesome.
Thanks for being here, guys, and thank you, Minas, for setting this up. It's awesome.
Awesome. Thank you, everyone. Thanks for joining.